Is looking at patient education, but patient education with a difference, and looking at how patient education can be made interactive, fun, and informative. So I'm very pleased to welcome to the stage Stéphane Jacquemet, who is a psychologist from Switzerland, who's going to explain to us the approach and some of the theory behind it. But he tells me in a very engaging and exciting way.
Thank you, Sue. It's a pleasure to me to be part of this session. It's a great pleasure to meet healthcare provider and patient association. And as psychologist, I will try to give you some fresh impression of education. Fresh because my challenge is to say in 20 minutes that learning is not giving information to patients. It's very basic, it's very simple, but it's a very hard challenge for all the actors, all the healthcare provider intervenant in this field of chronic disease. Sorry. So I would like to propose you just after lunch activities, and then, sorry, you can have this a very old studies about patient view and physician view. We have not so much studies where physicians and patients, the same physician and patient, but I do nothing. Magic. So my surprise is just finished now. We don't have a lot of studies where we have interviews of patients and interviews of physicians who are follow up those patients. It's very hard. So just a few minutes to think about this question. What are the view of physicians reverse patients about difficulties of compliance in nutrition to follow a diet every day? Okay? You have different proposals, like I have difficulties because my environment, private, professional environment. I have difficulties because of stomatic symptoms, sign. I have some problem because my motivation is down. I have a lack of information, and maybe some other. Can you just, with your neighbor or inside your brain, find the chart, the ranking given by physician and given by patient? Now you know about Let's say physicians say, okay, chronic disease and chronic treatment is basically a question of wish, motivation. Okay, you have the energy, everything will go down. It will be okay for you. And maybe you need more and more information, because if you have some difficulties, it's because you didn't understood the advice. So motivation and information will be the solution, viewed by physician. And we ask to the patient the same question. And the result is this. It's because it's difficult to manage the diet with daily life, private, professional life. I have a lot of signs and symptoms every day because I try to change my habits, because I try to change my diet. I have some stomach problem. I have some feeling of having to be tired, to be a little bit down. It's difficult to have a diet everyday life. And my motivation is very difficult because I'm alone with my friend, with my wife, but I'm alone. Information is not a problem. So if you can just underline this point, we are not in the same planet. we are not talking about the same problem. And the main aspect on this is when patients talk about motivation, they are talking about, I try to catch, to be motivated at the same level that my doctors, my nurse, give me energy, give me esteem, give me a good feedback. So my motivation is not only a personal problem, it's a question of relationship. So you can see, before starting education, we have a big challenge to speak about the same thing, to speak about the same challenge when we are talking about diet, which is very simple. The question is why it takes so much time, so long time, to accept an idea, a new advice, a new diagnosis, a new treatment. Why it takes so long? And sometimes it takes so long because the information, the point, is because it's right. Right means until today, what I did every day was wrong, maybe. Wrong. So I feel guilty. Every day until now, I know that my health was good, and suddenly my health changed. It's not right. It's not justice. I'm a victim. And everything I know about health will change because the physician and nurse will give me new advice. And everything is new. It's a discovery. So when physicians or healthcare providers are talking about information, they believe that the quality of information will give us the possibility to have new comportment, new behavior, good behavior. But it's not simple, so simple. There's a lot of factors, a lot of components in this area of chronic disease. As you can see, as you know, maybe, I don't have time to speak about all those items, but as you can see, for example, self-esteem, self-confidence will be a very important predictor for the compliance in long-term disease. For example, the change management, capacity to change in my life, not only for disease, for my private life, for my professional life. For me, it's easy. For my friend, it's not so easy to change. Locus of control. All my life, I have internal control. Everything I should take power on my life. Or, for my friend, everything are coming from outside. It's not my fault. It's not my responsibility. And then all those biopractical ways, all those issues will have a big impact on the compliance prognostic. Let's talk about just one very important aspect, which is very difficult for physicians. Side benefits. How can you understand that to be sick, to have a disease, could be an advantage for my life? And maybe I can keep my disease unbalanced to have advantage of my disease. Since the diagnosis is coming, my son will take some news about me every week. Before not. Now I have some right. I have some funds to take a taxi, to have some discount. I know it's very difficult to understand, but to have a disease can have some benefit on your social life and the view of your neighbors, of your family. And some patients will use, conscientiously or not, will use this situation to take advantage. It's normal, it's life, like a survivor. So we should be very, very careful with all those mechanisms because they will impact very, very deeply the skills, the behavior, and the motivation of patients. We use in practice, before education, to be sure that we are talking at the same level, that we are really on the same back. This model, just 4 questions, very important question. Just to understand, just one answer could be no, just one, among those 4, just one, and the prediction of compliance and motivation and durability in treatment will be maybe difficult. Just one answer for the patient. Are you convinced that you are suffering from a real disease? For sure, but we are talking about syndrome. Syndrome, what does it mean, syndrome? Is it a disease? Trouble? Risk? Cardiovascular risk? What does it mean, risk? You know, so a lot of people know that they have a problem with his health, but it's not really the same to say, okay, it's a real suffering disease every day. And maybe my motivation and my relationship with physician and healthcare provider can change because of my answer. Do you think that the disease will have consequence on your health in the long term? It's a question. You can say yes, you can say no, you can say I don't know. It's very important to have this answer from the patient to understand at what level or to what level of acceptance the patient is. So, do you have a disease? And do you believe that this disease will be very important and will have consequences on your health? And then, do you think, or do you believe that the treatment that we will propose to you, the treatment will help you or not? A lot of patients say that, okay, the disease, it's very difficult, but the treatment is more than difficult. So, you know, the problem starts with the treatment, not starting with the disease for some chronic disease. So we should be very, very attentive, very close to the patient, because as healthcare provider, we give opportunity to have treatment, but this treatment is a very bad news for patient. Sometimes better than the disease itself. And then, okay, you propose to me a treatment, but this treatment will have positive impact compared to the cost. It's a question of cost benefits. What kind of benefits for what kind of effort? Is it okay for you? Do you accept this? Can you be able to do this or not? So I'm repeating. Just one answer for the patient, just one no answer to the patient, and the prognostic of compliance is very down. And behind those ideas, there is a lot of conception, belief. You know, this is the health belief model de croyance de santé. There's a lot of beliefs, a lot of ideas, which are not wrong or right. It's just the idea of the patient. And then we have to work with. It's come from a long time. It comes from a long time. My power, my capacity to cope with the disease will be mainly because, in my mind, with the support of all the healthcare providers and all the intervenants, but in my mind, I will try to remove some ideas. I will be able to learn, not by myself, alone in front of internet, but with the help of all the intervenants. I do change my conception, not because physicians give me advice, because they will help me to make reflection, to have time to balance the proposal, and at the end, I will be able to decide. But just at the end, not because one person give me an advice and say, tomorrow you will have some injection or you will have some pills. So I come back to motivation because it's very, very often, very often we are talking about motivation with physician. Oh, sorry. It's yeah. Yes. 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 Very often motivation is going is going on the table as a problem. You know, it's like at school. At school, we have the same with teachers. You know, the school's result is not based on the work of teachers. It's based on motivation and the work of students. They are not so motivated. And then motivation is coming very often in the discussion with a physician. And the message is just to say, okay, just be careful. Patient needs to receive a lot of energy. If you say, his or her, she is not so motivated, the real question is, as a physician, as a healthcare provider, I'm not so motivated. I'm not able to motivate patients. It's my responsibility. It's my power to give esteem, confidence, and capacity to patients. So if you didn't understand the first slide, now you can go back and, you know, it's like Instagram, huh? Like boomerang. Sorry. Yeah. Sometimes we go back a few times in the same idea. So the question of motivation is very, very important because it's so simple to say he or she is not motivated. The question is, our program, our consultation, my relationship is enough motivating for patient or not? I had a lot of experience of auditing and evaluating programs, patient education programs. There is a lot of programs where it's very, very difficult to follow. It's very sad. It's very, very difficult to have this kind of energy coming at the end of the workshop. You know, at the end of the workshop, patients are leaving the room with a very heavy piece on their shoulder, not with the energy to say, okay, tomorrow I will try to do something. So motivation is a real challenge. And we say in the training of physicians and nurses, motivation is a social progress. It's an exchange in between two persons. It's not a state of himself or herself. And then we go to this kind of model of education, which is not giving information. Maybe some part of information are important, but the main challenge is to be sure that we are three in the room, three actors, three components. The healthcare provider, teams or physician, nurse, the patient as an individual, as a person, and the disease and the treatment, because it's not a person, but it's something in the room we are talking about. Very important. It will change my life for years and years, decades. So this relationship in three actors should be very, very well done by the physicians and the nurses. The first relationships, as healthcare provider, what I can give to this situation, this setting, because I'm an expert. I know the disease, I know the treatment, I make some studies, so I can give some advice. But I know that my advice are a very little part of the challenge. But I can give some advice because I'm an expert. I have not the experience of disease. I have the expertise of disease and treatment by study. And then, very important, we have to support patients. We have to help them. Very often, healthcare provider told me that what is very important in education is to listen to the patient. Yes. But we are listening what? We are listening the answer to the question that we are giving to patient. So if we are asking questions very far from the reality or too theoretical, we will have answer very bad or not useful for patient. And at the end, the patient will say, okay, it was very interesting, but I didn't learn nothing. But she was very nice. She was so nice to take time for me. I say she because sometimes it's dietitians or nurses. It was so nice, but nice is not to help patient to learn. So to give support is one part. To give advice is another part. And what we try is to give counseling. And counseling is to help patient to have this capacity to discuss by himself, by herself, with my support, to discuss the situation. Should I go? Should I stay? Maybe I can, maybe it's not time. It's too early. Maybe I won't, but I haven't the support in my family. So, you know, this triangle is very important because we can give some advice, we can give some support and motivation and valorization, but we should introduce in patient education what we call cognitive conflict, discussion, dialogue, debate. Otherwise, we have just something like, you are a student, I am an expert, I give you some advice, and then you are leaving, and tomorrow you do by yourself. Okay? Okay, let's do it. And now for 50 years, we try to work with patient education, and we have no big result on compliance. Patients who are very close to physician and very respectful of physician will take their treatment. Patients, we have more difficulties, more questions in their mind, more debates. They don't want to accept so easily. They will take treatment with very much difficulties. So what we try to say is, okay, information, advice, let's try. Okay, listening, support, valorization, okay. But what we can do is to create a brainstorm, let's say brainstorm, une tempête dans la tête du patient, a brainstorm in the head of the patient, because he should make some good decision, not my decision, but his, her decision. And maybe the treatment will come in 2 weeks, in 2 months, or it will be different, that's what I propose. So what we call mediation is, I am a supporter, I am an expert, and I am a mediator. I can create some debate, some question, very difficult question for patient. Advantage, disadvantage. I want, I don't want. You know, this is the balance, the motivations balance. It's very important in the patient education model. So to do this, what we are doing? We are trying to work on the individual, the action, and the result. What we call individual. Are you able to do this? Are you confident? Do you have support? Is it time for you or not? Maybe your private life is not on time for this treatment. So everything about the person. Action. What is the treatment tomorrow? You should go to the freezer. You should go to the sleeping room. What you are doing? When? In which order? What is the chronological way? First step, second step. Do you have alternatives? Oh, my doctors told me that I have to have some walk, 30-minute walking. Okay, where you go? I don't know. Okay, you can go through the park, Oh, good idea. 2 months later, people come back and say, oh, you know, I didn't walk. There's a lot of snow. Ah, yes. And then I say to myself, I didn't give him the possibility to think about another plane, le plan B, B plane. It's my responsibility. Otherwise, we say, okay, patients, it's adult, they are very autonomous. No, we should try to work on person, action, concrete action on the real floor, close to the ground. And we have to talk about result. What kind of result? What kind of cost? Do you think that it's okay for you? What kind of risk do you want to take? I want to have a good quality of life with my treatment. Good quality of life, we say, okay, treatment, but not the weekend. That's the quality of life. Should we have some advice for this? No, because we say, no, 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 no. Treatment, 7 days a week. And then after that, you can have some studies about the relationship between patient and physician, where patients are lying to their physician. I take the treatment. Yes, 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 yes. I take. So information is very important, but it's not enough. Information is just, in the area of relationship. It's not in the muscle, in the action. We should help people to go into the action. And not only with muscle, but with energy, esteem, self-esteem, confidence, and maybe it's not possible. But we'll try to find some solution, individual solution. And then, to know and don't act is not knowing. It's just a knowledge. But in fact, it doesn't help people to learn and to act in daily life. So if we are going into a program, we will have after that different example of program. What we can find in those programs, basically, not only a speech, like a small talk like I'm doing now, but we can find some workshop where patients should analyze this situation, their own situation, situation from other patients, real patients, case study. So they should analyze. They should say, oh, this situation is the same for me. I will do that. Oh, no, this is crazy. I don't want to do the same. This person is not real. I should analyze this. I should mobilize myself and give some proposal as patient, because physicians and educators will help me to challenge this situation. I should be able to have some reasoning. I have to solve situation. Okay, tomorrow your wife is offering you a weekend to Bordeaux, but you have your disease and your treatment. But you have some friend waiting for you for a good event. What are you doing? Yes? No? At which conditions? What is the challenge for you? This is problem solving. If you know education, now in the medical faculty, we are trying to change education in problem solving, not only listening and have knowledge. Judgment. Patient should be able to judge himself, herself, physician, other, quality. This is a good behavior. This is not a good behavior. I will do the same. I don't like this. If we want to have patients active in their treatment, we should have patients active in their learning before to be active in the treatment. So to be active is solving problem, analysis knowledge, exchange with patient, finding solution, and so on and so on. And healthcare provider will be only the mediators, the supporters, and not the expert giving information. And we try to help patients to have some adaptation with just one rule, just one law. I can live for decades and decades. I need to have a lot of different rules. For summer, winter time, when it's raining, when it's sunny, when I have some friend, when I'm alone, I cannot challenge my disease with just one rule. So I should be helped in the capacity to adapt my situation, to find solutions, alternatives. And we know that in chronic disease, a lot of patients need to stop the treatment to be sure that the treatment is the right one. You stop the treatment, you have some symptoms and say, okay, that's the good treatment. I will start again. So that's the evolution of motivation and confidence. Otherwise, I take the treatment every day without any question. Just the same. Every time the same. But life is not like this. So we try to work very closely with patients. Did you understand the why? Why you are here now with this disease and with this treatment? If not, we are not good enough as a healthcare provider. If you are not understanding why, we should be better as provider. How? The how. Every day, tomorrow, after tomorrow. Solutions. Did you understand the how? And are you ready to do this next week or not? Because your job, because your son, because your study, are you ready or not? And if you are talking about the why, the how, and the when, we are sure that we are really in support of the patient. I don't want to go back too far with the WHO definition, but when you read the definition of WHO, the main word is skills, ability, capacity, not knowledge. Skills. And then to develop, to help people to have skills, as trainer, as educator, we should have very flexible attitude. We should have, as healthcare provider, very flexible attitude. What is the good solution for Peter, it will not be the good solution for Jack. Otherwise, it's so simple. Otherwise, we don't need patient education. We make some DV audio, and we send to all the planets the same message. We should take into account the needs, specific needs, to build some individual program approach. And then we should be close to the real life of patient and the problem of healthcare provider, which is not a critic, it's just a fact. They are not living with the disease. They are working with the disease. They are not living with. But it's not a critic, it's just the gap that we should to manage in the relationship, and patient education try to manage this gap, considering patient as an individual with a real life, with disease and treatment, and healthcare provider as expert, far from the disease, but very, very helpful for knowing some knowledge and helping patient to think about the situation and to find the best way. So at the end, I'm coming from Geneva, so close to the Alps, the guide. Not too fast, but close, and giving the direction. Otherwise, you are just saying, okay, where you want to go? Okay, for me it's okay. This way? No, I'm not a guide if I say, okay, this way, this way. No, I'm a guide because we have a challenge, and I try to give the direction and to give some motivation. Help when it's needed, and sometimes I can leave the person going through. Very difficult for physician healthcare provider. Talking about dialogue with patient about disease and treatment. Not giving advice, talking with. I am not living with the disease, but I should take a seat and have the ability to ask questions, to ask good questions. It's not a consultation, an amnestic consultation. It's really a dialogue where we try to push the patient to be sure that this way is the best way. If not, I will try to find another way altogether. And to coach. Just remind, motivation is very, very central. So every hour, when I come to my physician, it's my consultation from the last 3 months. Friday, 5 p.m. Friday, 5 p.m., 3 months. Hello, Mr. Jacquemet. It's okay? I'm tired, you know, as physician. I'm tired because I start Monday morning. You are the 65 patient this week. So I'm burned. But I'm here for you. So what I say, it's because I have a lot of respect to healthcare physicians, but they should understand that they will give energy to patients. They will give this capacity to challenge the disease. So to coach, it's very important. Close, but not in the real life. I will not with you. I will stay just behind the line, not on the field. But I will be there. And I will give you some esteem, some confidence. And I will close this small talk with this very interesting sentence. We should be sure that it's not what we didn't know, but what we are knowing, and those knowledge are not useful. So patient education is not giving more and more information. It's to help people to change their conception of life, disease, and treatment for the next few decades, because it's very difficult and challenging for people, patients, and family. Thank you for your attention.
Stefan, thank you very much for your insights into the thinking that's helping shape the more progressive patient education programs. And now I'm really pleased to welcome to the stage Professor Joel Constans, who will share examples of some of the educational programs that they've developed and are using at the Bordeaux Hospital. Thank you.
Thank you. So I will show practical examples of therapeutic education programs in systemic sclerosis in Bordeaux and in Lille with Eric Hachulla. So, waiting for presentation. Okay. The therapeutic education program in Bordeaux was developed from 2011. It was coordinated by Karine Boulon, who is not able to be here today, and it's a very multidisciplinary approach with medicine doctors from different specialties, with nurses, ergotherapists, physiotherapists, and patients. So, the development of the program was carried out from 2011. First, the topics were chosen after investigation among patients, and the results of this investigation were presented during a meeting of the Patients Association in December in 2011. Then a multidisciplinary team was created with patients to develop the program. This program is made of 8 workshops, 3 individual consultations. The first one is educational diagnosis, and there are 2 other consultations for follow-up and evaluation. And the administrative authorization was obtained from January 2015. Patients complete a cycle of therapeutic education in 4 months and choose the workshops during the educational consultation. 6 months after they may have a follow-up consultation, workshops are made for 6 or for some of them 8 patients, and all workshops are done by a pluridisciplinary team and expert patients. I'm going to give examples for each workshop very briefly. The first workshop is about what is scleroderma. We use this method with the body, and the patients have to indicate which part of the body are involved in systemic sclerosis. The second workshop is about prevention and risk factors of digital ulcers. We use Barrow's cards in which you have sentences, proposals, and the patients say what they think of what is proposed. Third workshop is about dressings and digital ulcers, and we use pictures for photo language and dressing sets with different kind of dressings that are shown to the patients who can just use them. The fourth workshop is about Theumatological involvement, and we use real written stories from patients and different scenarios of articular, tendinous, and muscular pains, and we use Metaplan as a pedagogical method. This workshop is about preventing disability, and ergotherapists and physiotherapists are mainly involved in this workshop. They demonstrate self-massages and orthesis. Sixth workshop is about how to monitor my disease and how to identify a complication. The aims of this workshop are to explain explorations and their aims, and to know and to explain signs of worsening of disease. We use picture commentaries. 7, digestive involvement in my disease. We use pictures and clinical stories. And the last workshop is a speaking group. Patients may participate, but their wife or husband may also participate and just speak about what is the disease in real life. So, in conclusion, the Bordeaux Therapeutic Education for Sclerodermic Patients is one of the programs that have been authorized by authorities in France. There also are programs in Lille, in Paris, and in Montpellier. We'll have Lille example just afterwards. These education programs were developed according to patients' needs, and patients were implied at each step of the development of the program. At the time, 65 patients participated to this program since 2015. Developing a program is complex. It's heavy because of heavy administrative time to develop the program and then to evaluate the program. But we think that the patients who participated felt that this was very useful. Here are Dr. Karine Boulon and other persons who participated in the program with patients and nurses. Thank you for your attention.
Thank you. And next up, we have Professor Eric Hachulla, who will be telling us about some of the tools and techniques that they're using at the Lille Hospital.
Good evening, everybody. We are involved in patient education for roughly 20 years now in Lille. And I want to know who has already been involved in an educational program so far in the audience. Can you tell me who was already involved? 1, 2, 3, 4, 5, 6. So very, very few patients. And this is one of the major issues of patient education, is to reach patients. Because in France, patient education is mandatory. It's written in the hospital law. So normally, for all chronic disease, physicians have to propose to the patient an educational program. And thereafter, the patient can accept or not, of course. if I give you a pill to treat your Raynaud's phenomenon, you can accept or not. You have the decision of that, you know? And patient education is the same. And I will give you the example of Lille. You have to have in mind that patient education is like flights of stairs. And the first step of this flight of stairs is the educational diagnosis. And the goal, as you can see, on the top is a better knowledge of the disease and to make you a partner of care. And this is, of course, possible because as a patient, you know well the disease. You are living every day with the disease. So the first step is educational diagnosis. What is the educational diagnosis? It's not a common visit with a physician. This educational diagnosis can be done by the nurse who is trained in education for the patient, or by a physician. And this is a face-to-face discussion with the patient to understand what the patient knows about his disease, to understand what the patient knows about his treatment, also to understand what are the consequences of the disease in his daily life, on his work, on his social activity, on his familial activity. This is a very important step in patient education, to understand the environment of the patient. And this takes at least 45 minutes to 60 minutes discussion with the physician or the nurse. And this is the first step of patient education. And thereafter, that first step, we give to all our patients here this small book. It's Systemic Sclerosis, 100 questions and answers for the patients, with very simple words to explain scleroderma to the patient. This is information. It's not completely education, but it's the first step after the patient diagnosis. Thereafter, we propose to the patient a personalized program based on our program. Our program is based on roughly 11 or 12 different workshops. And after the discussion of the patient has to choose 3, 4, 5, 6 workshops, or if he wants, all the workshops over a 1-year period. Some workshops are on Raynaud's phenomenon, other on dyspnea, other on gut involvement, reflux, other on to understand my treatment, for example, to deal with fatigue, etc. And so the patient can choose what he wants. It's a personalized program. And thereafter implementation, we use educational techniques, and also patients has to reformulate what he has heard. And for that, there are different techniques. We can have interactive presentation with a physician or a study nurse and with the patients. It can be face-to-face, one patient, one study nurse, or one patient, one physician, or sometimes 3, 4, 5, 6, 10 patients, also possible. We have round tables and discussion between patients, because what a patient tells to another patient, it's really important. Sometimes a patient believes more another patient than the doctor about, for example, dealing with fatigue or some advice for reflux. So discussion between patients is very important. As Monsieur Jacquemet said, skills, patient skills, and when patients have skills, they can give advice to other patients. We use also play role or photo languages, for example. And we have a room dedicated to that. And here, discussion with physician, with a nurse, and a nutritionist on diet in Scleroderma. And so this kind of workshop takes roughly 1/2 hour or 2 hours of discussion altogether to give the patient more knowledge on his disease.
For starting,
to make the patient a partner of care with the physician and with the nurses. And we use different tools that we have built especially for the Scleroderma workshop and Scleroderma programs. For example, that house with different rooms, what is dangerous in the different rooms or in the garden, and how to avoid the different, the dangerous situations sometimes in the daily life. We also use other tools, particularly the Scleroderma quiz, Sclero quiz, that if you want, we can play together at 3 o'clock in a French session this afternoon, or at 4 o'clock in an English session. And that game is very interesting because we can discuss about the knowledge of the disease that the patient have, about in general question about the disease, general questions about the treatments, general questions about to live with, or what is an autoimmune disease, for example, what is systemic, when we say systemic sclerosis, etc. And all these questions have different levels of difficulties. And so different teams are playing together, and this gives some emulation between the patients. And on the top, of course, we have to evaluate the skills and the knowledge we gave to the patients. And for that, we have some questionnaires. And you can see, for example, here, the evaluation of a patient program. At the end, we ask the patient, before beginning the program, on one part of his disease, complication. Do you know about a complication of your disease, of Scleroderma? And here, in 10 group patients, 6 said, yes, yes, quite know some things about. And 4 said, yes, I know much more about the complication. And after the program, everybody except 1 said, yes, I know everything about the complication of the disease. And it's so important for the patient and also for the partner, because, of course, the partner or the helpers are invited during the patient education session or workshop, because they have also to know more about the disease. And to finish now, because one of the major issues of patient education is that we can reach only roughly 10%, 10 to 15% of all our patients. It's not enough. It's because our sessions are usually on Friday morning between 10 and 12, and it's not possible to come in the hospital every Friday for all the patients. And so we are now in the reflection in my department and also in France to develop educational therapies. So with a physician or a nurse in face of her computer, and to reach all the patients by computer at home. And this may enlarge the population that we can reach, I think. And maybe if it's not possible for you to come at the hospital, maybe it's possible to connect at home and to be a partner in a workshop on a specific topic in which you are interested in. And to finish, I want to acknowledge my team involved in Scleroderma and connective tissue disease in Lille, and particularly 3 of them. Here, Sandrine Morel, physician and involved in patient education for 20 years now, or 15, 20 years. Partly also Géraldine Condette, a nurse involved with me for 20 years now in patient education, and Hélène Maillard, another physician involved in patient education. Thank you for your attention.
As you may have noticed from the programme, we were due to hear from Janne about her own personal experience of being involved in the patient education programme. And as some of you may know, she had to go to hospital this week for an operation for a digital ulcer. I do understand that she's made really good progress, and we do send her our best wishes. We've got a very short space of time left. Are there any questions? We've got time for a couple of questions. Don't be shy.
Oui, bonjour, Alain Trollet, qui est suivi à Saint-André avec le professeur Constans. J'ai assisté à plusieurs ateliers thérapeutiques qui sont très bénéfiques, surtout en groupe. Voilà, ma question est, dans les thèmes que j'ai bénéficié, je n'ai pas vu actuellement, je dirais, comprendre son traitement ou voilà, connaître ces médicaments, à quoi ils servent, voilà, pour mieux comprendre pourquoi on nous donne tel médicament. Alors, est-ce qu'il existe l'atelier que je n'aurais pas vu, ou est-ce que ça ne serait pas une piste? Je dis ça parce que j'ai bénéficié, à la suite de ma rééducation cardiaque, un atelier thérapeutique pour le cœur où les médicaments étaient expliqués. Voilà.
Thank you.
Alain Trollet is participated in Bordeaux in the education program. His question is about therapies. He says that there is no workshop about how to understand therapy, how to better understand treatments. So I think he is right. And all these programs are made to improve. And this is a good idea to improve the program, I think.
I'm afraid we have run out of time, but I think there's going to be ample opportunity if you want to go to play the quiz either in English or French. I think there'll be an opportunity for you to ask further questions. So it just remains for me to say a very big thank you to our speakers, and if we can show our appreciation.